over to Alicia, if you are able to share your screen with us, Alicia, and thank you so much for joining us. Alicia?
Yes.
Oh, great. Okay, super.
Can you see my screen?
Um, yes, yes, we can.
Okay. Okay. Hi, good evening, everybody. So I'm going to start this evening before Karen, who is going to, she is a lived experience, and she's going to then end off the session. But in thinking around this evening, it's really going to be talking about the shift or shifting from looking at disabilities as deficits to dignity and acceptance. And I think this is where or how we could look at being proactive about protecting the mental health of particularly childhood onset disabilities. And so, the greatest disability is often not in the child, but it's actually in the assumptions that we make about them. And for the longest time, the medical model has focused on what's wrong with the child. And it's about diagnosis and interventions rather than actually looking as to how we can support the child with disabilities, be it physical, be it intellectual, be it mental. And so this evening, I'm really hoping to shift the lens from looking purely from that point of deficit to looking at dignity and acceptance. So the real source of the crisis is really the gap that is created. And when I talk about the gap, it's the gap between who the person living with the disability is and how the world responds to that particular individual. And the thing about mental health challenges is that they are often not caused by the disability itself, but they actually emerge from the gap between who a person is and how the world responds to them. And that's where the crisis lies. And I think that is quite a gap in terms of, the mental health crisis. And maybe just to start off with a reflective question in terms of what is harder, living with a disability or living in a world that constantly reminds you that you are different. And I think that's something that you can even reflect upon after. But it really is thinking around what is actually harder, living with the disability or living in a world that constantly reminds you that you are different. So I want to start by introducing Sarah. So Sarah's 12. She has cerebral palsy. She's also obsessed with Taylor Swift. She loves animals. She's funny and she's really bright. But I want to ask you a question in the sense that what was the first thing that you noticed about Sarah? Please be honest. Because oftentimes Sarah's disability entered the room before she did. And so it becomes about Sarah, who's 12, who has cerebral palsy, rather than Sarah, who's obsessed with Taylor Swift like any other 12-year-old. She loves animals, she's bright, and she's also funny. And the problem then with this thinking or the deficit thinking is that we have the child, we know all the deficits and we can list them from A to Z, so the deficit may be you know, in terms of the physical disability, a child can't walk, they can't write, they can't communicate, they can't keep up. Therefore, this leads to diagnosis, and then it leads to intervention. But the entire conversation becomes about what's missing, not how can we support. It's all about what's wrong and what's missing in that child or the individual. And, mental health difficulties or concerns, or mental health suffers when a person constantly hears who they are not. But that's also been the narrative that is being part of our view in terms of how we even view disabilities in children. And the difficulty, or with regards to childhood disability, there's definitely an increase in mental health concerns. Children with disabilities, adults with disabilities are more at risk for anxiety, depression, social isolation, bullying, trauma, low self-esteem. But the mental health difficulties are often missed by professionals, because there is often the risk, or oftentimes everything is attributed to the disability. So we see the disability before we actually see the person. And this then sort of leads me to my next part of the talk, where, we call it in clinical practice, we call it diagnostic overshadowing. So what that means is that it's when a physical disability, an intellectual disability, or autism causes professionals to overlook acute mental health symptoms. And this is where children fall through the cracks, because everything becomes about the physical or the intellectual disability, at the expense of that there may be an emerging mental health concern. And oftentimes the mental health problem or concern actually creates so much more distress. And oftentimes these are treatable conditions, but because we kind of dismiss it, so oftentimes it'll just be, she isn't anxious, that's just the cerebral palsy, or he isn't depressed, he's just autistic, as though somebody with autism can't be depressed, or he's withdrawn, that's just his disability. And so there's often this overshadowing, where there's an over-reporting or over-emphasis on the disability, and the mental health concerns are often then missed. But what is it that actually harms the mental health? Because the diagnosis, particularly, with physical disabilities, intellectual disability, mental health disabilities, the diagnosis is what we see. So, we'll see a person in a wheelchair, or we'll see the walking difficulty, or the speech difficulty, or the learning delays. But oftentimes that is not the root cause of the psychological harm. The root cause of the psychological harm is what's underneath the iceberg. That's things like rejection and bullying or exclusion as a result of disability, that constant comparison, particularly in the family systems where, siblings are compared to each other, feeling like a burden or a chronic misunderstanding. And, the thing about that feeling like a burden, oftentimes, even within the home environment, where it's, no, but you're not telling somebody they're not a burden and then feeling like a burden are not the same thing. Also loneliness and shame, and even identity struggles. These are often the root causes of the psychological harm, not the diagnosis that we see. And there's also, an invisible cost to masking, because oftentimes, particularly with children and adolescents, they will mask symptoms, particularly the neurodiverse adolescents, where they will act normal so that others feel comfortable. So they mask the disability. And so a child can look successful, but still be internally struggling. And so, particularly with the neurodiverse individuals, you're going to get burnout or identity confusion, high levels of depression, exhaustion, and even anxiety. And so masking also then actually costs the individual. But as a function of adolescence, oftentimes, particularly adolescents, they'll mask their symptoms, but at quite a cost to their mental health. And then there are some red flags that we shouldn't ignore. And, in working particularly with children and adolescents, the biggest shift for myself has been that, children and adolescents, they communicate via behavior. They can't articulate how they're feeling, but we'll see it before they are able to articulate or tell us. So behavior is the communication. But it's around thinking about, what is this behavior trying to communicate? What distress is this behavior trying to alert us to? And so some of the things, in children with disabilities are things like a change in mood or a loss of interest. So it's also thinking around, like from a developmental point of view, what does a loss of interest look like in an 8-year-old versus a 16-year-old, which is different to an adult. A child who participated in extramural activities and then doesn't want to do them anymore. Oftentimes it's subtle and it's often missed because it's just, they don't want to do it anymore, when actually that may be that they've lost interest as a result of an underlying struggle. A big one is sleep changes. I once read a book that said the greatest measure of wealth is a good night's sleep. And so with regards to sleep changes, it's either difficulty falling asleep, difficulty staying asleep, or early morning awakening. That's a significant red flag when sleep is disturbed. Or even, increased withdrawal, isolation. With children, irritability in particular is a big red flag, in that a lot of mood difficulties or mood disorders present more with irritability rather than depression, or irritability rather than anxiety. So irritability is, in my mind, to child psychiatry what a fever is to a pediatrician, because it is such a non-specific sign, but it can actually indicate quite a few underlying distress. Another one is school refusal. Children don't just wake up and decide they don't want to go to school. It's either that there's something happening in the home environment or there's something happening at school. So when I get a referral for a child who's school refusing, already in my mind, I'm thinking, where's the distress? Is it that there's separation anxiety, or is it that there's bullying at school? Or does this child actually have some kind of a learning difficulty, which is not evident because, yes, cognitively they may be okay, but there's something that's hard for them that they're not able to articulate. And when something is hard for a child, then they don't want to do it anymore. Also, the increased aggression, or even just regression from a previous level of development, particularly with adolescent self-injury. Oftentimes that's quite different from, it is different from suicidal ideations. Self-injury, oftentimes the underlying function is there's some distress, or there's some function that the self-injury is actually assisting with relieving. And also if there's expressions of hopelessness. And again, we have to consider where kids are developmentally. Bullying is a significant risk factor for a child versus, as adults, we're like, but just get over it. This is not going to matter in 5. But for kids, it's a big risk factor. And so when children then sort of express hopelessness, or it really does matter in terms of the meaning of the stressor for that developmental stage, rather than what us as adults might perceive it to be. And the thing about disability is that, yes, there may be the child or the individual at the center, but disability affects the entire family system. And so it's not only about, looking after or assisting the child, but the caregiver. And there've been studies, done that show that caregiver well-being actually predicts child well-being. But that's just across the board. Healthy parents, healthy children. Unhealthy parents, unhealthy children. So when I have a child, in front of me, and there's difficulty and distress, oftentimes the caregiver is distressed. And so with regards to the caregiver, it's so important also to look after and actively and intentionally look after the caregiver's mental health, because as caregivers, burnout is a real thing. Financial pressures, isolation, guilt, grief, grieving the child that you wanted to have or could have, should have, and also just the chronic stress of caregiving. And, the reality is that you can't pour from an empty cup. And so taking care of your own mental health as a caregiver is actually part of the treatment plan. And it's part of the therapeutic intervention, because if you are not okay, it's very hard for the child with a disability to be okay. And so it's really thinking around these two lenses of care, and how do we move from this deficit model to the dignity model, which is, for me, the paradigm shift. And so if we look at these two lenses of care, the deficit model, the core question is, what's wrong with you? And that's oftentimes when, we label kids oppositional defiant, they are naughty or lazy. But with the dignity model, the core question is, what happened when your brain, your body, and environment met? So it's a function of your brain, your body, and environment, or the systems that children exist in. With the deficit model, the focus is merely on the symptoms of the disability. Whereas with the dignity model, the focus is the symptoms of the environment. How do we support the child with with a disability? And with the deficit model, the goal is about fixing the child, or, getting to a sense of normality. Whereas with the dignity model, it's about participation and quality of life. And, particularly with the neurodiversity movement, it doesn't deny that there's a disability. And that difference is real. But it's about thinking around supporting, and how can we support the individual to exist in a neurotypical world. But it's about the dignity that needs to come first. And I think that understanding goes a much longer way than just merely labeling in terms of what's wrong. It's about what's happened or what's happening when all of these factors collide. Somebody asked before the webinar, like, what happens when therapy reaches a plateau? And so, again, it's about shifting the view, because in the medical view, that plateau could mean a failure to progress or a dead end. But in the dignity view, that plateau could be a landing pad or base camp for adaptation. And sometimes when it's at a plateau, it may not be that it's a failure. Sometimes that's the point of adaptation. And so it's more helpful to then ask, what is the next meaningful goal, rather than we are failing to progress. So it's the kind of moving from fixing to, is the individual able to live? Moving from independence, because maybe it's not about independence, but about participating and also moving from normalcy to what is the quality of life rather than we are aiming for this individual. The only way that success is measured is if the individual be, for me, it's more about quality of life rather than normality. Then it's also important in terms of how we explain disability to children, because the language that we use is so important. And so it's not about denying the disability, but it's about naming, because if we can name it, then we can tame empowered thing. But we've got to in with learning difficulties. It's really, and if there's physical disabilities or intellectual disabilities, it's really that for a young child, it's the understanding that your body or your brain works differently. It's not broken. It doesn't need to be fixed. It's just different. And we need to figure out how your body works, how your brain works. In primary school, with kids, a better way to explain disability to them would be that everyone has strengths and challenges. And so it's thinking around what are your strengths and what are your challenges. But it's in the context of we all have strengths and challenges. Whereas with adolescents, it would really be, because they're moving into the next developmental stage, it would really be around your diagnosis explains some things, but it's not what defines you, because adolescence is that period of who am I in the world, who am I in relation to others. So yes, the diagnosis explains some things, but it's not what defines you. And so I'm nearly at the end. We're talking about, dignity, or how do we move from deficit to dignity in practice. And, what children tell us they want is not, they don't want our pity. They don't want inspiration, and they don't want fixing. And children with disabilities, they want the exact same things as every other child. They want to belong. They want to contribute. It might look different, but they still want the same things. They want to be heard. They want to have friends, and they want to have purpose. And so they don't want pity. They don't want inspiration, or they don't want to be fixed, because the truth is they're not broken. They're different. And the 4 questions that would be helpful to ask every child is: what is strong? What is hard? What helps? And what matters to them? And if you notice the moving from human flow, and that's changing the questions that we ask. And just to start, in the deficit model, we're asking what's wrong. But with dignity, we were saying how children with disabilities.
Okay, I think unfortunately we lost connection with Alicia there. There seem to have been some technical challenges, but hopefully Alicia is going to join us again after that. It really was a fantastic approach for all of us to have when dealing with children and adolescents and young adults who have childhood onset disability. So, Alicia, I'm sure will be back. So if you had any questions that you did want to ask her, we will have her join us again after Taryn has presented. So, Taryn, I would like to oh, there's Alicia. Okay, sorry about that, Alicia. I think we lost
I'm here.
connection with you. Yes, sorry.
Can I finish off?
Yes, absolutely. Thanks.
Okay. The paradigm shift is moving from, the the clinical labels to human flourishing. And that requires changing the fundamental questions that we ask. And so, it's like with children who require accommodations or concessions, it's dispelling this myth that, this concessions or accommodations puts children at an advantage. No, it's about equality and equity and putting them on an equal footing rather than this is an advantage. It's what is needed in order for them to flourish, and they're not just surviving, but they're then thriving. And then if we return to Sarah, she still has cerebral palsy. Nothing had changed about her body. But now we know that she writes poetry, she worries about friendships, she dreams of becoming a teacher. So the diagnosis didn't disappear, but the person appeared. And our shared responsibility as professionals is to see the person before the diagnosis. And oftentimes there's a big reliance on what's the diagnosis, but actually we need to see the person first. For parents, it's about protecting the identity. For schools, it's to create belonging. And for society, it's to move from awareness to acceptance. How do we accept in the sense that this is different, it's not broken, nor does it need to be, nor does anything need to be fixed. And just to end off, I think the ultimate goal is not to help children become less disabled. The goal is to help them feel more human, more valued, and more fully themselves. And that is how we move from deficit to dignity and ultimately acceptance. Thank you.
Thank you so much, Alicia. That really was fantastic. And I think it's so fitting now that having heard what you've said and the key things that we need to look out for and the whole dignity model, it's so fitting that we have Taryn join us. Alicia will welcome you back at the end. I think there will be some questions, but Taryn, I would just like to introduce to everyone, Taryn Go is a bookkeeper and a peer counselor, but she's also very importantly an individual with lived experience of cerebral palsy. Taryn is also one of our EXCO members at SA-ChilD, and part of her motivation and ambition is to share from her experiences, what she's been through as an individual with lived disability of cerebral palsy, and has a particular heart for adolescents and young adults. So, Taryn, we are very grateful to have you join us tonight and to just share from your perspective, growing up with a disability, encountering adolescence and all of those challenges as well. So we welcome you to share your story with us.
Thank you so much, Jacqui. I really, really appreciate it. It's such an honor to be able to talk after a presentation like that. Sure, Alicia, that was really beautiful. Thank you. So I would like to start by saying to the parents who are here, who are struggling, you are doing an amazing job. I made notes for tonight, and then I got my mom to read them. And then I said to her afterwards, did you ever get to a point where it just became too hard for you? And she said to me, if it wasn't illegal, I might have killed you. Not because of your disability, but because you were defiant and difficult. That defiant and difficult child was also a fiercely independent child. And she made me that fiercely independent child, I just want to say, and she will admit it. My mom was determined that I was going to be the most independent cerebral palsied human being on the planet. And I was not allowed to feel my feels because I grew up in the 80s and children were seen and not heard. And I had major sibling rivalry because I'm one of a twin. And my sister, please don't misunderstand me, I love her to bits. She has given me two of the most amazing nephews and the most amazing niece. But there was fierce competition because we were twins. We do have the twin connection where we know stuff has happened to the other one. It's a very weird thing to explain, but she was, in her mind, a caregiver for me. So there was a lot of emotional resentment for her as well. And I just want to point that out at the start, so that if you have other children, or if you have families who have more than just a special needs child, please bear the siblings in mind. My older brother was my hero. He was the one person who treated me like there was nothing wrong with me. He threw me around. He taught me how to abseil of my parents' garage. He also taught me how to jump off the garage roof into our neighbor's swimming pool. All things I don't highly recommend to anyone today, but 80s children will be 80s children. What I will say is that I was, from the outset, Miss Personality at school. Everything was always good. Everything was always happy. I was in a really great primary school where I was treated lovingly. I had therapists who really cared. I had teachers who were so kind to me, and the school really had a focus of what you can achieve, as opposed to you have a disability you're not going to achieve, which is what I encountered in high school. So although I was in this great school environment and everyone thought I was doing okay, when I realized how different I was, and that took me a while because I had grown up in this home where I was expected to do everything my siblings did. And I went to a school where all the other kids, oh, shame for them, but I didn't realize that there was something different about me until one Friday night. And I remember it so well. I can tell you what I was wearing, and I was in primary school. I was walking through an Edgar's store, and I saw my reflection in a mirror as I was walking. And I suddenly realized, walking beside my twin, how differently we walked beside each other. My sister has this ballerina figure. She's like beautiful posture, all the things. And then there's me with my bent skews, very scoliosis body. And I realized there was something terribly wrong. And I knew there was something wrong. I'd had what felt like a million surgeries by the time I was 12. My perception of my primary school years is that I had surgery every single July school holiday. Apparently, that's not true, but that's what it felt like to me. I was isolated because I was in casts and I didn't get to see the friends that I had. And so I knew I was different. I'd just never seen it. And I was around 12 and I was leaving primary school, going into high school, going into a school where I knew no one. And I had suddenly realized how different I really was. And I had my first very real depressive episode when I hit grade 9. Just doing the maths quickly because it was different when I was in school, grade 9. And all of that was put down to she stopped having surgery. She's realized her body is different. It was never seen as depression. And because my parents, who are amazing parents, were going through their own stuff, they didn't see it. And I was very good at masking what was really happening on the inside of me. And I learned how to lie. It's a terrible thing to say, but it really is the truth. I would tell people I was absolutely fine. I would be smiling and happy. And on the inside, I was so broken and confused and devastated by how difficult life was and how different I was. And it drove me to be as fiercely independent as I could possibly be, because I was never going to be a burden to anybody. And if that ever happened, I would just end my life. That was like the decision I made at 14. And I moved out of my parents' home at 30 after 6 years of negotiation with my dad. And it was a negotiation because my father is fiercely protective of me, and he didn't think I would manage on my own. And even when I bought my own home, I was not allowed to have a fridge or a dishwasher or any major household appliance. So it was a fridge, a washing machine, or a dishwasher, because when I moved back into their home, I would have to take those things with me. So for 3 months, I didn't have a washing machine, a fridge, or a dishwasher. I had a little bar fridge, and I would take my laundry to my parents' house. And after 3 months and 3 broken washing baskets, I spoke to my mom, who spoke to my dad, and I was allowed to buy appliances for my house because he agreed finally that I might actually stay in the house I had bought. Going back to my teenage years, I had really good friends, great friends. I am still friends with many of them today, but none of them knew how much I was struggling with how different I was. I spoke to one of them today to get her perspective of me as a teenager, and she said to me, I don't think you realize how much you spoke about your disability when we were in our teens. It was such a big deal for you. For me, I didn't talk about it at all. So our perspectives were very, very different. And she was my best friend well into our 30s until our lives took very different paths. But she was very real with me. And she said to me, you obsessed. And I think I was very real with her because I felt safe. And I could say to her, I hate the fact that I look so different, or I hate the fact that I haven't achieved the life goals that you've achieved. And those life goals were as simple as starting my period, or my body starting to develop, or because all of those things were very delayed for me, which is not apparently normal. It was very, very delayed, and I just wanted to be accepted, and I just wanted to be normal. I just wanted something normal to happen before I finished school. Like, I just wanted to be a normal girl. I wasn't. And if I could talk to my 14-year-old self as a much older woman, I would say, celebrate your difference. But I can tell you that if someone had told me at 14 to celebrate my difference, I would have wanted to slap them through the face and tell them to try celebrating their difference when they're disabled. It's very hard when everyone can see what is wrong with you. You know, I knew my friends were going through struggles, but they could hide theirs. When I was having a bad, very spastic day, because I have spastic cerebral palsy, everyone got to see it. When I lost my balance because I wasn't feeling well and I misjudged a flight of stairs and I fell down the stairs and broke my coccyx, everyone got to hear me scream out loud and get carried. Oh, I'm probably going to still blush. I was carried by our PT teacher, who happened to be incredibly good looking, Mr. Martin. I was carried to the sick room because I couldn't walk because I'd broken my coccyx. The amount of teasing and bullying I got from my classmates about being carried by Mr. Martin was ridiculous. Now I'm not just disabled and different. Now I'm disabled with a broken coccyx and sitting on a donut or lying on the donut or just being even more different. And I didn't participate in sport anymore by choice because life was too hard. It's exactly what Alicia was saying about withdrawing from something you loved. I loved sport in primary school. I raced my tricycle through the corridors of Forest Town School like an absolute hooligan. I'm still remembered for it, apparently, which is quite shocking. But I loved it. I loved being able to go as fast as possible and throw shot puts. And that desire just went away when I realized how different I was. And as I got older, because the focus had always been, we need to get you as normal as possible. So there was surgery after surgery after surgery after surgery after surgery, which I don't think is the way you do it anymore. Now all the surgeries are done at once and you have one major recovery. But there were a whackload of surgeries and they didn't make me any more normal. They made walking possible, and that was great. But I distinctly remember after having my Achilles tendons lengthened, I'd been in plaster casts for so long that when they cut off the bottom half, skin came dropping off and the smell was so bad. I remember that smell. And I remember the physiotherapist who cut it off. She was so polite and so kind. But she just said to me, we're going to phone your mom and we're going to get her to fetch you because we're not going to let you go to class like this. And there was all this dried, icky skin where the cast had been. And my mom, for the first time in my entire life, my mom took me home and she said, you can run as much hot water as you would like in the bath because you haven't been able to actually bath for weeks. I'd been bed bathing. And that was a big deal in our house because we were a lower income family and hot water was electricity and it was a luxury in winter. It was hard. It was tough. I remember really liking a boy and that boy really liking my best friend and him using me to get to her. They dated for 6 years. He and I are still friends. He and I have worked through that, but it was hard for me to be the go-between girl. I have been the go-between girl many, many times. I've been the go-between woman many, many times. I would also like to say to medical professionals, get to know your patients. As an adult, I started seeing my GP in Joburg when I was 20. We worked it out yesterday. I was 20 the first time I saw him. I stayed with him. I followed him from practice to practice to practice until 2023 when I moved, 2024 when I moved to Cape Town. I was only truly transparent with him when we were 20 years into our doctor-patient relationship. And I remember sitting with him one day and saying to him, this is so hard to be an adult with cerebral palsy who has lived so much of a lie that I'm battling to work out what is the truth of my life and what is the I'm okay, I'm fine, I'm all good when I really wasn't. And I've just had enough. And I looked at him and I said to him, Pete, will you please put me on a drip and end my life? I know you know how. Will you please just do it? And he, being the loving and diplomatic man who knew me so well, he sat next to me on the bed and he said to me, I do know how, but I've taken an oath to do no harm. And more than that oath, I answered to a God who is going to ask me how I chose to end your life and why I chose to end your life. And then I looked at him and I said to him, I don't agree with the oath because I don't think that my death is harmful. But I do agree with you about the answering to God. So I will let it go this time. And when I was genuinely suicidal after I had had COVID and went from being a girl who could walk to a girl who could no longer walk and was confined to a wheelchair, I didn't tell anyone how much I was struggling, but I was really genuinely looking into assisted suicide. And I have a whole folder on my laptop of what it will cost. I am a bookkeeper by trade. I had 3 different spreadsheets for 3 different countries where I could fly in. I could justify why assisted suicide would be an option, and they would do it. And then I looked at how much it cost, and I didn't have the money. So I had to understand that I am here for a reason and I have to live a dignified life. And what does it mean to live a dignified life? It's to make good choices even when life is hard. And to know that even when life is hard, it is also good. And that can be as simple as I was able to get myself out of bed this morning and cuddle with my dog. Or it can be as good as, today was a really good day. I walked with my walker, I rode my trike, I did all the things, and I managed to put on mascara without sticking the mascara wand in my eye. That's a major achievement when you're me. So there are the really good days, which seem totally insignificant to an able-bodied person who doesn't have to worry about sticking their mascara wand or their eyeliner pencil in their eye. And then there are the days where I just make it. And getting up is my achievement for the day. Getting up and getting dressed. Those are the 2 things I do every day. Get up, get dressed. Get up, get dressed. Get up, get dressed. It's because there are days where it's hard for all of us, whether you have a disability, whether you're caring for someone with a disability, whether you are a medical professional dealing with disability, for which I have so much respect because they vary so very, very much. It's tough. And it's hard to explain to people who don't know what you deal with, what you deal with. It's hard for me to sit and explain to someone how I make it through a day when I am constantly in pain. It's hard for me to explain how I find joy in a day when it's a difficult day and I just don't want to, but I choose joy. I make a concerted effort to be grateful. I live in the Helderberg Basin, and the way that our house is situated, I can look outside my door and I look out on the Helderberg Mountains, which are spectacularly beautiful. I cannot tell you how much joy just that brings me. Looking at those mountains and being in absolute awe of how spectacularly beautiful my view is. Bearing in mind that I come from Joburg, where my view was a wall with an electric fence. And when it wasn't that, it was out of the gate onto a veld with power lines. So sometimes it's the small joys, sometimes it's the big joys. The big joys for me are things like I took 2 steps today. That was such a big deal for me. The first time I took 2 steps after being in the wheelchair for 2.5 years, it was such a big deal to me. I was so excited and I expected my parents to share in my joy. And my mom was like, I don't know if those were steps. They just looked like wobbly movements. I think my mom was so afraid that I was going to fall that she didn't take the moment to enjoy the fact that I had walked and moved independently. Let's just go with moved independently. I am grateful that I am alive. I live with an attitude of gratitude, and that is so cheesy, and I know I sound like Oprah when I say it. And the next thing you're going to think is then I'm going to tell you to get started a gratitude journal. I'm not, but I am going to say if you're a caregiver to a child, you do need to ask questions. And the questions I ask myself when the emotions get way out of control are 5 W's and an H. What am I feeling? Why am I feeling it? When am I feeling it the most? Where do I feel this thing the most? Where am I? Where in my body? When I'm feeling this the most? And so I've done. And why? And then the H is how do I move on from what I feel? I write those things down for nobody's benefit but my own. And because I have the worst handwriting in the whole entire world and didn't want to mess up any journals, I literally write them down on scraps of paper and then I throw them away because I cannot like my handwriting. I never will. So I've just learned that writing it down on a piece of paper and throwing it away works for me. And there is something, I actually read some research on it, but I don't have that with me now. There is something about writing something down instead of typing it that actually makes your brain more cognitively aware of your experience. So write down what you feel, and it is okay to feel what you feel. You just can't stay where you're feeling. You're never going to always feel happy. You're never, I mean, if not for the antidepressants, I would probably be addicted to Valium because it helps me feel nothing. And if I could find a doctor who would give it to me, I would take it. But I have addiction problems, so we don't get those. Can you tell that I loved Valium? From the age of 12, I was given Valium at 12 and I loved it. So if your child is given a medication that has addictive properties, be cognizant of that. If you are a medical professional giving medication that has addictive tendencies, watch your patients. I was addicted. I used to suck up the Valium syrup off my sheets if my mom spilt it, and I would make her mess it on purpose. I was that child. They don't make Valium syrup anymore. I'm very disappointed. But as you journey through life with your special needs child, know that they will be with you for the remainder of their life or yours, whichever ends first. My hope is that mine will end before my parents, which is why I worded it that way. so that they will have some years where they don't have to worry about me. Because I do feel like a burden to my parents, even though they tell me I am not. They can tell me that until I am blue in the face. I live in their house now. I cannot live without them. My independent years are over. I would like them to know what life is like without having to take care of me. Love your children. Just love them. That's all I wanted, was for my parents to love me, and they did it well.
Thank you, Taryn. Thank you for such an honest account of your experiences. I think all of us are just feeling very privileged to have heard your story and to have gleaned so much wisdom from your life and your words of encouragement and your coping mechanisms that you've used to help you through this. And we are so grateful that you've been with us tonight. You are such an asset to SA-ChilD. So on behalf of SA-ChilD, we are so thrilled to have you as part of our body of sharing knowledge and support. So thank you so much. I'm looking at the time and we have filled an hour. I we don't have any questions in the chat. I think you and Alicia, I don't know if you want to just pop back on again, but both of you have done such a sterling job of taking the time to read through. We had so many questions before the webinar, and both of you have just integrated them so beautifully into your presentations that I think you've covered a major part of the questions that our attendees were coming tonight with. Yeah, and there's just some messages of thanks in the chat group. Alicia, is there anything that you just want to add at this stage, or so if you have anything more that you want to say?
I mean, I just think for me, the challenge is about how we view disability, and that to say that moving from the medical view of the deficit and all the things that are wrong to the view of what is happening and how we can support. And I think that's the move that's afoot. And I think that's the challenge for all of us, be it practitioners, be it parents, be it educators, even, lived experience. It's that moving from what's wrong to what's happened.
Yeah. No, and I just want to thank you both for taking the time to tackle such a very, very valuable topic tonight. It is something that we've been wanting to do for a while at SA-ChilD, and I think it has been a really educational experience for everyone who's joined, to hear from the healthcare practitioners, but then also very importantly from the individual's lived experience as well, because there's such a wealth of knowledge from both sides of the story. So then just to then end off, to say to everyone, thank you so much for joining. We do have some exciting news that in August, SA-ChilD is going to have our second conference. It's going to be on the 13th and 14th of August. The program is going to be released soon. We're going to be tackling topics such as DCD, autism and caregiver support for autism. We're going to be looking at pain management for individuals with cerebral palsy and other childhood onset conditions, and then also looking at a different framework for cerebral palsy and our interventions there. So please diarize the 13th and 14th of August. For those of you that have joined for the first time tonight, if you are interested in becoming a member of SA-ChilD, you can look at our website, and easy process to join, to become part of the emailing and information sharing that SA-ChilD is doing. So again, just thank you very much again to Taryn and for Alicia for wonderful presentations tonight. And to everyone else, have a great rest of the evening. Thanks, everyone.